Hello, and welcome to AMN's What I Wish I Knew Before I Became a Psychiatrist. My name is Leah Grant, and I am the Divisional Vice President with AMN Leadership Solutions. First and foremost, thank you so much for joining us today for our presentation. This panel discussion is brought to you by AMN Healthcare, specifically Merritt Hawkins, and we are honored for the time and insight of the three panelists that will be introduced momentarily. To provide some background on AMN and Merritt Hawkins, for the past 30 years, Merritt Hawkins has been the leader in physician recruitment, working to earn the trust of employers and physicians alike. Our partnerships with leading healthcare systems and practices allow us to provide candidates with the best permanent practice opportunities in the country. Merritt Hawkins is a part of the AMN Healthcare family, which is the leading healthcare staffing and technology solutions company. I am honored to introduce and be joined today by my colleague, Michael Belkin, who will be the moderator for today's event. Michael Belkin is a divisional vice president and plays an integral role at Merritt Hawkins, leading all of the recruitment for diversified specialties, advanced practice providers, and key account delivery teams for the company. Mike received his bachelor's degree in business and German from Lehigh University, graduating cum laude. He completed his Juris Doctorate in 1997 at the University of Pittsburgh School of Law and is currently pursuing a Master's of Science degree in Health Administration at Texas Tech University. He is a fellow of the American College of Healthcare Executives and is board certified in medical practice management by the American College of Medical Practice Executives. As a key player in the healthcare recruiting industry since 2004, Mike has been involved in several thousand search projects with clients ranging from small to large practices, from complicated teaching health systems and hospitals. Without further notice, I'm going to pass it over to Michael Belkin for today's panel discussion for What I Wish I Knew Before I Became a Psychiatrist. I hope you each enjoy. Mike?
Thank you so much, Leah. It's a pleasure to be here, a pleasure to visit with everyone that's joining us this evening, and really honored to have our panel members join us to talk to us about a very dynamic field. Psychiatry is such an important specialty. We know how important behavioral health is. It is a factor each and every day. I wanted to introduce our panel members to you and allow them to talk a little bit about themselves, perhaps take a 3-minute introduction to talk about who they are, what their specialty is, their title currently, their background. So let me start with our first panel member, Dr. Krugley.
Hi, thank you very much. My name is Richard Krugley. I've been practicing psychiatrist for over 40 years, actually about 45 if you count my residency training. Currently, I'm the Director of Consultation Liaison Psychiatry at Mercy Hospital, actually. They changed their name from Medical Center to Hospital, in Rockville Center, New York, which is on Long Island. I also consult at several nursing facilities. In the past, I've had a variety of positions as a medical director, director of inpatient services, director of geriatric psychiatry at a variety of different facilities and health systems. So right now, I'm kind of at the tail end of my career and eager to share my experiences with the audience. Thanks very much for having me.
Thank you, Dr. Krugley. Let me ask you, can you share one fun fact about yourself?
A fun fact. What would be a fun fact? Well, I've been married to the same woman for 48 years, and that's been a great ride. And quite a bit of fun, actually.
Thank you, Dr. It's an incredible accomplishment. Wonderful, wonderful. Thank you for all that you've done so far for the profession. Let me introduce our second panel member. If you wouldn't mind just going through the same introduction of yourself, and let me pass it over to Dr. Wacom.
Yeah, thanks, Mike. So I'm Dr. Ryan Wacom, board-certified psychiatrist with a special focus on interventional psychiatry. I had actually started my first group practice as a third-year resident, and then opened a second one as a fourth-year resident. Kind of was blackmailed into being the chief resident at the time. And then since then grew it to 7 group practices, and recently actually joined or partnered with an organization out of Massachusetts. I'm located in the Pittsburgh region, Pittsburgh, Pennsylvania. So, and recently changed to chief medical officer over that entire organization. Right at the moment, we have 24 locations, soon to be 40 within the next 3 months or so. We specialize in just outpatient mental health, so psychotherapy, psychopharmacology, with again a subspecialty or intervention arm for TMS, ketamine, Spravato, looking at some of the other psychedelics coming down the pipeline. But because of our size and scale, we do a lot of inpatient work as well. We oversee a lot of acute hospital inpatient units, detox residential programs, and do a lot of telehealth too. So I, at this point, sit as a chief medical officer. Super excited to be here tonight and, kind of go over what I wish I knew. And a fun fact about myself is I used to be a scratch golfer before med school and residency and everything else. Now about the only thing I can do scratch is scrambled eggs. So that's about as good as it gets.
Thank you very much, Dr. Wacom. Some real cutting-edge interventional psychiatric procedures. Really excited to hear more from you. Third panel member, Dr. Carter. We're going through just introducing ourselves, our history, our training history, our current title, and a fun fact about yourself. Dr. Carter.
Hi, everyone. I'm Dakota Carter. I am a board-certified adult and child and adolescent psychiatrist. I, too, started my private practice when I was a third-year resident and built a private practice back in Texas, where I'm from, and trained. But early in my career, almost directly out of residency and fellowship, I became a chief medical officer of a hospital in Texas, and have recently transferred up to Denver, Colorado, where I serve as chief medical officer of 2 hospitals. There's nearly about 200 inpatient beds that I am administratively over every day. And then, of course, I'm helping with outpatient PHP, IOP type level of care, as well as the inpatient folks. In my still short career, I've also done some work with residential treatment centers. And so even though I haven't been doing this a super long time, I have had experiences in private practice, in residential, and inpatient and outpatient care. So lots going on, and also do a lot of academic teaching and all that good stuff. So actually invited some students tonight. So if you guys are watching, welcome. And other than that, fun fact is I keep being a little bit jittery. I have a new puppy that I got yesterday, and he keeps doing flybys and biting my toes. So if I see him a little jumpy or anxious, it's probably trying to avoid getting bitten. So he's a great new guy to the family, but that's a fun fact about me.
Thank you, Dr. Carter, and welcome. Incredibly distinguished 3 panel members. We've got some prepared questions for you to really talk through your personal thoughts and feelings about the field of psychiatry. The first question, very open-ended: do you feel you made the right decision to go into psychiatry, and can you please elaborate why? And let me start again with Dr. Krugley.
I would say unequivocally the answer is yes. I was although this was, I don't know how directly connected it was. I was a psychology major as an undergraduate at City College in New York. But I went into medical school with an open mind. I found, even at the medical school level, I found psychiatry to be intellectually exciting. And I still remember my first day of residency, which was actually on Labor Day weekend, and I was on call. And I was assigned to cover the Kings County Hospital, what at the time was called G Building, which was a separate building on the Kings County campus, a true nut house. Very, very busy, 50 emergency room visits a day, half of whom were admitted 7 days a week, 52 weeks a year. And my first exposure that first day was to cover the emergency room. And I still remember that as being one of the most exciting days of my life. That first day, I said, I'm in the right place. This is for me. And at that time, there weren't even that many psychiatric beds or emergency services in the entire borough of Brooklyn, which is 2.5 million people. So it was a very, very busy place, very exciting. We saw incredible, not only numbers, but range of pathology, range of presentations. Brooklyn's not organized like that anymore, but it was thrilling. And I went from there to Bellevue Hospital was my first job, and I got a lot of great experience there as well. So I've had ultimately went into geriatric psychiatry, and I've had as I said, the original introduction, over 40 years in the field, and I've had a great career. Don't really regret any of it. The last 2 years have been, when I say last 2 years, I mean the COVID years have been a little bit more problematic. I don't know how everybody else has been affected by that, but overall, I would say I have no regrets whatsoever. Had a great career, learned a lot. Taught a lot of people, other psychiatrists, psychiatric nurse practitioners, psychologists, medical students, geriatric psychiatry fellows. So it's been very gratifying for me. The patients I treat, the families that I have worked with, all very gratifying. As we know, can't help everybody, but when you do get the opportunity to actually make a difference in someone's life, and they acknowledge it, it still remains a very gratifying experience for me. So I encourage everybody who's listening out there to get excited, stay excited. It's actually the field is going to, I think, evolve in a very positive and interesting way over the next 10 years. Not sure how long I'll be around to see it, but I'm very excited about what the future holds for psychiatry.
Thank you very much, Dr. Krugley. What an incredible career, and thank you for mentioning so many different stops along the way. Dr. Wacom, same question. Do you feel that you made the right decision, and why?
Yeah, I'll echo. I don't quite have the experience as Richard, but I will echo the fact that when I landed in psychiatry, when I started medical school, I'm an individual who wouldn't have been able to tell you the difference between a psychologist and a psychiatrist. But when I ended up picking psychiatry, I saw, to extrapolate from what Richard said, a lot of both opportunity and purpose. And there's a lot of specialties in medicine that maybe don't quite have the same opportunity into the future. There's so much we still even don't know today about the brain and brain function, and so the opportunity to get involved with interventional and some of the stuff that we're kind of leaning towards into the future now has been extraordinarily rewarding for me. And very purposeful. And again, to Richard's point, we can change lives in a different way. We're not performing, brain surgery, but we are in our own way, and we can save lives without touching a patient. Now, not if you're doing interventional, but we can engage with people and change a life. without ever having to pick up a scalpel. And for me, that was a really cool concept. And again, I found a lot of purpose and opportunity in doing that. So don't regret my decision, and looking forward to many more years and what the field will look like over the next 5 to 10 years specifically.
Thank you, Dr. Wacom, very much. Dr. Carter, lastly, do you feel like you made the right decision to go into psychiatry, and why?
You know, I was telling my students just a couple of days ago that I didn't really choose psychiatry, it chose me. I had been convinced I was going to be a pediatrician and that I was going to save young lives and do all that. Realized very quickly that my favorite part of my job was talking to kids, not helping folks with runny noses and talking about their issues at home and in school. I come from an education background, so it was really important for me to integrate those things that were just so important to me and understand those types of issues. And psychiatry, particularly child psychiatry, was what really drew me to that. I will back up and reiterate everything that the other two gentlemen have said. It's very true. Prozac, one of the newest, SSRIs that's not so new anymore, came out within my lifetime. And it's become the standard of care. It's consistently changing with interventional psychiatry, with medications, the way that we're interacting and understanding the brain. It's the forefront of medicine at this point. And I tell all of my students and residents is I may never treat diabetes again, but you can guarantee that if they're in another specialty, they'll be interacting with a psychiatrist or psychiatry patient going forward. That also being said, just would reiterate too, with the mental health shortages that there are in the US, the job that you want and crave can be created and molded into whatever you want it to be. And so if it's inpatient work, outpatient work, a little bit of both, if you want to work in residentials, if you want to work within schools, if you want to choose a certain population that's important to you, Native American mental health, LGBTQ mental health, there are tracks and niches across the board that you can choose. And some of those have fellowships, some of them have extra training, but you can really make your psychiatric future and your career into whatever you want at this point.
Thank you, Dr. Carter. We're going to stay with you for this next question. Obviously, we have a lot of residents that are listening into this discussion. If you think back to you as a resident, and you can go back and talk to yourself while you were in residency, what's one thing that you would tell yourself knowing what you now know?
Get more time with your favorite professors. Those folks are gold. And I think it's really important to recognize those folks that you have that bond with and to pick their brain, discuss, to talk. I think that was probably the one thing that I missed the most being out of training is those folks that were just literally an office away, a phone call away, and still are in some senses, to have that shelter of education and being able to discuss and talk about cases and really taking that opportunity on. I think also within just residency itself is if there's something that you're not seeing in your training, ask if there's opportunity or elective time to go do that. And so, for example, TMS was just kind of coming out and becoming a forefront when I was in residency. I asked for rotations to do that. I wanted to be part of that and be engaged with interventional psychiatry because I knew that's where the field was headed. So I think just advocate for yourself if you're seeing something in your program that you haven't had a lot of experience with or wanting to engage with, is ask if there's an elective. And I think the other key piece too is my administrative background. You don't get taught that in training. So if you have any interest in leading organizations or trying to build procedures and policy, ask folks that are doing that if you can do an administrative elective with them. If you'd like to learn aspects that are still very important within medicine, but that may not be just clinical in nature. I have residents that rotate with me now just to learn the nuances of having to argue with payer mixes and how do you create a policy of safety on a unit. And so those types of rotations are vital too, just to build your leadership skills. because there's not only a need for psychiatrists, there's a need for leaders in psychiatry.
Thank you, Dr. Carter. Very good advice. Dr. Wacom, same question. If you could go back to yourself while you were in residency, what's one thing that you would tell yourself then, knowing what you now know?
Yeah, it's a great question. And actually, Dakota took a lot of what I would have answered, which is, there's definitely power in knowledge, and you don't get taught business and generally in, medical school or residency. So understanding medical, reaching out, mentoring, understanding medical business, to Dakota's point, there's a lot of need, not just for direct patient care, but also for administrators and leadership within the field of psychiatry. As it continues to expand, there's a lot of APP programs with specialization now in psychiatry. So there's a lot of people that need administrative support, and there's not a lot of that education in residency itself. And the other one, again, just from my background and what I do a lot of now, is that interventional piece. When I was in residency, TMS was a thing, but it was a very nebulous thing, and not understanding it, or understanding the opportunity in it. It took me years to do that outside of residency. And had I engaged in that earlier, it might have been a different trajectory from where I am today. But those two things for me are what I would have wanted to know then that I didn't know at the time.
Thank you, Dr. Wacom. Very, very helpful advice. And lastly, Dr. Krugley, what would you say you would tell yourself if you could go back to residency?
Yes. Well, I think Dr. Carter's emphasis on mentoring and mentorship, seeking out mentors, is extremely important. I actually was thinking about making reference to that before we started, when I was preparing in my mind the importance of mentorship. As far as I had a strange experience, though, that people don't have anymore during their residency training. I trained in the 70s at a program that was actually dominated by psychoanalysts. And we were, and the residency group was fairly large, and we were working at a city hospital with very difficult, seriously mentally ill patients. But the teaching program and the mentoring that we received in the residency was all about psychoanalysis. That was, I don't know how many people remember this, but in the 60s and 70s, psychoanalysis was the dominant school of thought in general psychiatry. And the particular residency program that I was at was dominated, had actually an American Psychoanalytic Association Institute, the Downstate Institute, and the department was dominated by psychoanalysts. And we were being taught to interpret psychotic patients' delusions. It was pretty wacky. There were only maybe 2 or 3 people really in the teaching program that were interested in psychopharmacology. So we were very much oriented to psychoanalysis. And I really was, I was thinking about this before, most of my useful mentorship occurred after my residency. My first job at Bellevue, which was 5 years. And then I, after that, joined a private practice that was involved in geriatric psychiatry. And those 2 experiences, which probably covered about 9 or 10 years, was really where I was mentored and really learned how to practice psychiatry. The residency was more of an intellectual exercise, and I really don't use much of the information that we were kind of exposed to back then, although the listening skills were important. But I think the most important thing for early career psychiatrists, people in their residencies, I would echo what's been said. Look for mentors, look for people who you can learn from, look for people who you feel you can relate to, and seek them out and learn as much as you can. I would definitely go with that.
Thank you, Dr. Krugley. For this next question, we're going to focus on the various settings for a current psychiatrist, being opportunities for outpatient, inpatient, variations of different varieties. To please share about your current setting. What do you like about it? Why do you think it's an advantage? And what should residents think about if they're considering going into a setting like yours? For this question, let's start with Dr. Wacom.
Thanks, Mike. So our current setting, as I mentioned early on with the Transformations Care Network, it really is an outpatient mental health platform. So that is, psychotherapy of all sorts, psychopharmacology, and interventional, as I mentioned. As I also said earlier, we do end up covering a lot of inpatient facilities or detox residential programs in some of the IOP, PHP stuff, just as a subset of having a group of providers in an area where there's obviously shortages across the board. So, I'd say the advantage to us is we have the flexibility of kind of creating a job for someone. That could be a mix of tele and in person. It could be a mix of interventional and psychopharm, outpatient. It could be a mix of inpatient in the morning, outpatient in the afternoon. So that flexibility again is powerful. In terms of thinking about what you want to do, it's not mutually exclusive. So some people do only inpatient, some people do only outpatient. You can mix it up. Again, there's the flexibility of inpatient or tele versus in person. So generally speaking, outpatient is much more structured. So, it's a schedule, you follow that schedule, people show up, people leave. Inpatient, and so by nature, outpatient's also a long-term treatment rapport and planning, where inpatient tends to be much more in and out, short-term stays. You're the treating provider for a short period of time. You're not kind of their long-term primary provider. And inpatient generally comes with more flexibility. You can kind of create the rounding schedule when you want to and kind of leave when you want to. You have a captive audience there that you're serving, kind of not the other way around. So, how important your day-to-day schedule is, I think is an important piece of what you choose. If you want to be on call or not. If you're generally working inpatient, you're taking, overnight admission calls and, someone's getting kind of wild on the unit. They need some sort of chemical restraint. So there's, outpatient, you're really not on call, especially if you're in a group practice. There's probably someone who's been kind of designated to take whatever not, urgent, rare call there might be for the outpatient practice. So flexibility versus, lifestyle versus, time commitments. Do you want to work weekends, not work weekends? So the point being, they're not all mutually exclusive from one another. And, certain personalities fit certain opportunities better. And that's really what you have to line up as you think about what you want to do. As Dr. Carter said earlier, the jobs are there, the opportunities there, and you can usually get pretty creative about what you choose to do.
Thank you, Dr. Wacom. Let's go to Dr. Carter. Dr. Carter, same question. As you think about your current practice setting, other practice settings that you've worked in, what are the advantages and what should residents think about when they're thinking about their next step and what's the right setting for them?
So I think probably first and foremost is what is your personality? Just like Brian was saying, it comes down to also lifestyle. What is your work-life balance? We do hard work. as psychiatrists, and what can you, on your level, be able to handle? Are you wanting to see more acute patients that are in the inpatient or intensive outpatient programs? Are you wanting to be kind of like that old kind of family doc that becomes like a family psychiatrist and follow people long term? Are you somebody that's interested in doing more therapy than psychopharmacology? Those are questions that only you can answer. I think it also comes down to, are you someone that's an academic? Academic institutions, more or less, may have a smaller caseload and emphasis on teaching and research, or you might be a mercenary. You might be someone who wants to work for a for-profit organization and see 20, 30 patients a day and feel comfortable doing that. It's really based on your own personalities, your own perspective, and the care you want to provide, the life that you want to have. And you know, as a leader of a hospital, I can just tell you, negotiate for what you want. There's such a shortage. I promise you, they will find a place and plug you in your ideal situation.
Thank you, Dr. Carter. Great advice. Dr. Krugley, same question for you. All the different settings you must have worked in, what would be some of your advices? What do you feel residents should really think about as they're considering what they should do next?
Well, I've always been a hospital-based practitioner. Although the field in general is largely provides ambulatory care. Psychiatry is by and large an outpatient practice. So the inpatient setting, the number of psychiatrists who work inpatient is much smaller than the large majority of people who do outpatient work. I've always, well, until the last 5 years or so, I've always maintained an office, but it was more of a part-time situation at the end of the day after the hospital work. I also was introduced to geriatric psychiatry in the 80s and found a kind of a niche as a consultant to nursing facilities, which is I would call it a niche practice. So it's a facility-based practice, different than hospital. It has its own rules and regulations. It has its own milieu. It's a niche in and of itself, and you can include assisted living facilities in that as well. So, what's important is what you feel comfortable doing. I was always felt excited by inpatient practice. I've worked both in freestanding psychiatric facilities as well as general hospitals. They each have, they're different, and they each have positives and negatives. I think what I would recommend for people starting out is to choose a setting that they're comfortable in. I myself was comfortable in facilities and hospitals, nursing facilities. I like the interaction with the nursing staff, with colleagues, in general hospital settings, with other medical staff, other physicians. Office practice tends to be a little more isolating. I mean, you can be in a group and so forth, but everybody's kind of doing their own thing with their own patients. I think what's important for people in the residency or fellowship stage is to decide whether they want to start out in more of a general kind of practice or whether they want to start out more specialized, forensic psychiatry, child and adolescent psychiatry. I would recommend more of a general exposure for the first few years, especially in terms of seeking out mentorship kinds of experiences. But keep in mind that certainly the large majority of psychiatric providers are working outpatient. So that is where I think probably a majority of the opportunities are going to be. But if you're really interested in inpatient work, you have to seek that out. And again, pay attention to who you're working with. When you're starting out your career, you want to work with people who you can learn from. Very important. So that's pretty much what I would advise people to do at this stage of the beginning stage of their career.
Thank you, Dr. Krugley. Great advice from all three of you. The only thing I'll add is to confirm that there are many psychiatric opportunities right now in all different varieties of settings. So as you're thinking about your next move, there are different options, and it's also changed. It's no longer a stigma for a candidate to make changes. A couple of decades ago, if you were a physician that made multiple changes, that was almost a red flag to a future employer. In today's market, it's relatively common. It's okay to explore different settings. It's okay to try different things out until you find what you're truly passionate about. Great advice, great feedback. This next question, let me start with Dr. Carter. And Dr. Carter, if you can think back to your residency, what's one thing that you've learned in practice that's totally different than what you experienced during residency?
I had about 20 things pop into my head just now, Michael. I think probably most pertinent is you can't help everyone, and we all want to. And it's really hard to have those tough cases where you may just not be able to feel like you've done enough. Maybe the meds don't work. Maybe the resources just aren't there. So I'd say probably the first thing is residency is a little bit sheltered, where a lot of times the cases are managed or are moved on to other things. And in real practice, sometimes you have to be that one person making the call on whether or not you can handle a case or not. It's really, really hard. It's really, really hard. I think another thing that I would say that I would learn is there's a lot you don't get taught. You are taught the basics. You're taught how to pass tests. You're taught how to manage, but there are going to be things that throw curveballs. The brain is a strange, wonderful organ, and there are some things that we just don't know. There's things we don't understand. And it's okay to recognize and admit when you don't know something. I think there's also this idea, and I think this is across the board for physicians, to be afraid to ask for help. If there's anything I have learned is to ask for help, whether it's with clinical or administrative roles, is don't be afraid to be vulnerable. Don't be afraid to have case consultations. Don't be afraid to throw ideas off of other folks. Sometimes that's frowned against. I don't know if that's a residency thing or someone who becomes a physician type thing, but don't be afraid to ask for help either. Don't be afraid to say, I don't know, and reach out. Probably a whole lot more, and I could go on and on, but those are some big ones. Is you can't help everyone, ask for help, and just recognize that sometimes just showing up is part of the job, and sometimes that's enough the validation and support that you can give someone, maybe all that you can do, and that's an okay thing still.
Thank you, Dr. Carter. Dr. Wacom, same question for you. What's one thing that you've learned in practice that you really didn't think about during residency? It's totally different.
Yeah, for me, just given the way I progressed through my career thus far, it really was how to train others that weren't residents. So I was, I obviously was a resident and received training. Then I was chief resident and helped train. But for in my residency program, we didn't have at the time any APPs. We didn't have any nurse practitioners, any physician assistants. And it's a bit nebulous, like different states have different regulations around what they can and cannot do. Do they need a supervising physician or not? And so what I wish, or what I've kind of seen change over the last 5 years specifically, is there's a lot of APPs that are kind of flooding into the psych market because of supply and demand and financial economics and just supervising those individuals, I guess is a blanket statement. Educating them, based on where they come out in their career, and then supervision of them, into their career and working side by side with you, is something that, I had no idea about, had to learn it as part of my own group practice. And now, it's something we hold very valuable, is the ability to expand who we can touch with our care, without me or another physician having to do every single interview or every single direct patient engagement. So just that whole supervision structure, especially on an outpatient kind of group practice model, is something that I did not learn in residency that I wish I had, or that I know now, wish I knew then, wish I had some exposure to earlier in my career.
Thank you very much, Dr. Wacom. Dr. Krugley, thinking back to your residency and maybe just some of the things that are so different in current practice to what may be a resident's experience in the last 5 years or 10 years, or just in general, what would you say are some of the great vast differences that you've learned?
Well, some of this might be artifact in the sense of when I trained, but I would say the biggest difference for me between what I learned in residency and what I have come to learn as a practitioner is the importance of interacting and working with families of patients. And I say this may be artifact, but in the 70s, and even in my first job at Bellevue, we never, or I shouldn't say never, but rarely did we include families in the patient's care or treatment plan, or whatever interventions we were going to make. It was kind of based on that individual model, that confidentiality model. You saw the patient, and nobody else was allowed to participate, or certainly nobody was invited to participate. And I would say in the last, as a geriatric psychiatrist, I invariably include family. I have to include families. I'm working with older patients who are not the most reliable historians. And I've actually gotten to a point before I closed my office, when I was still seeing office patients, I insisted that a family member come with the patient to the appointments, because I didn't think the treatment could progress without a family member being present to make sure that the directions, the interactions were understood. I think going forward in psychiatry in general, the idea of seeing people one-on-one, well, yeah, it works in many cases, but I think the idea of including significant others and family members in the process, even if it's an office visit, I would say is something that should be seriously considered. I invariably, even now when I'm doing consults, whether it's in a nursing home or whether it's in the general hospital, I invariably, not every case, but probably 50% of the cases I see, I pick up the phone and I have to make a call to get the information I need to organize my thoughts and to do the right thing. So that's, I think, the most important difference between how I see things now and how I saw things during my residency and for the first few years afterwards, is being more inclusive of the patient's significant others and family members and so forth in the patient's overall care. That I think is a real difference for me.
Thank you, Dr. Krugley. Wonderful, wonderful words of wisdom from all three of you for our resident listeners. Want to go to the next question. The next question will be about telepsychiatry. And one thing that we've noticed as executive search consultants focused on behavioral health is telepsychiatry is becoming much more prevalent in the market, both between the candidates and our clients. What I'd love to hear from you, and I think what residents would really appreciate, is your thoughts of what you think telepsychiatry what role it plays in the current market, and how do you think telepsychiatry will develop and evolve in the future state? Dr. Wacom, let me start with you, please.
Yeah, thank you. So doing training in West Virginia during residency, there was a lot of rural communities that couldn't access mental health care. So actually, I trained a fair bit in telepsychiatry. So I had been doing telepsych work for years into certain outpatient settings and actually some drug and alcohol rehabilitation and detox programs. But obviously, one of the big hangups to that was technology in certain areas, which still exists, especially in, again, rural West Virginia and areas like it. And the other thing was just this barrier of either providers not feeling comfortable with it or patients not understanding or feeling comfortable with it. And, unfortunately, with COVID, that changed overnight, and it became not just doable, but in some instances, or a lot of instances, preferred for access to care and convenience, and a lot of different reasons. So, as someone who had been doing telepsych, for years pre-COVID, did it all through COVID, and then now doing it kind of on the hopefully what we would call the tail end of this. It is something, as I alluded to earlier, if you're not doing interventional psych and you're not having to place a coil on someone's head or push an IV ketamine infusion, you can perform a lot of what you need to do via tele. So it's certainly not something that's going away. I guess the third piece of the equation was payers, and what we've seen from payers, Medicare, and their stance is this is going to continue to be paid for. There's probably it's not very likely that this is going to be clawed back and the regulations are going to go back to kind of pre-COVID, at least not to the levels of pre-COVID. So, telepsych will be part, or certainly an option for care into the future. And then it really goes back to personal preference, and then the setting in which you're working. So obviously telepsych into a kind of an acute inpatient lockdown unit where psychosis or thought disorders might be common. Using technology in that instance, again, we had to, and we did it, but probably not ideal care, and probably not something payers will continue to pay for. But outpatient setting, less acute setting, it is convenient. There are advantages to it. And so I do think it's absolutely something we'll have to embrace we'll have to continue to embrace as a specialty, and certainly something that's here to stay. I don't know that you can get any more telepsych adept than what we were during COVID, where a lot of people were 95+% tele in a lot of organizations. But I definitely think it'll be a huge part of practice, and a huge option into the decades to come.
Thank you, Dr. Wacom. Very helpful information, learning your perspective. Dr. Carter, what are your thoughts about the current state of telepsychiatry and what role it will play in the future care delivery team of behavioral health?
It is here to stay. I've written chapters on it. I use it every day. I'm in between two different hospitals, so I literally across town trying to use it every day. Huge advocate. It's expanding access to care. It's a wonderful tool. Just some nuances, just from personal experience, is if you do want to go the telepsychiatry route, I would definitely talk to the organizations that you want to employ or go to work for. Understand what kind of EMR system they have, what type of virtual services that they're actually utilizing, and make sure, just at a very simple level, are they paper charts, which there's still a lot of organizations that are utilizing paper charting, or actually using EMR. When you think about that, it's the access of what type of care you're going to have. If you're using paper charts, the charts you're not going to see the whole picture of the patient versus their health history within an EMR. That may change your mind about wanting to practice telepsych with that particular organization. Some other just kind of nuances is understand too, the type of services that are going to be provided? Are you just being management? Are they able to access other types of services like therapy or other modalities that are needed? Who are you working with on the other side? Is there a nurse? Is it a mental health tech? Is it a clinician of some sort? Is that person someone that you work well with? And what type of culture are you going into? Are you somebody who is like me, just going across town and dealing with the same type of patient population? Or are you doing like colleagues of mine and practicing in an entirely different state? Do you have the ability to build culture and rapport with the patients that you're interacting with? I think particularly with telepsych, it's a wonderful tool, but there's a lot of nuances that some people think, oh, it's just turning on the screen and meeting a patient. Make sure that you're asking those important questions of what kind of resources and tools and experience that you and the patient may have interacting in that type of system.
Thank you very much, Dr. Carter. And Dr. Krugley, what are your thoughts and your perspective on telemedicine and what's going to happen in the future?
Well, I was first exposed to telepsychiatry over 10 years ago. I was partnered with a psychologist who was trying to start up essentially a telepsychiatry business, and we were working with an outfit from based in California called Forefront Telecare. And the technology was brand new at the time. And we were I was doing nursing home consultation remotely at facilities in upstate New York from my home. So I do have, a decent amount of experience with telepsychiatry. Now, I agree with what's been said. It's certainly not going away. But what I would say further is that psychiatry in particular lends itself to telepsychiatry, as we are not with the exception of, as Dr. Wacom says, with the exception of some procedures that we do, and maybe there's going to be more of those in the future, but the basic assessment is not a hands-on situation like it is with other areas in medicine. So it's a talking and listening paradigm, which lends itself quite well to telemedicine, telepsychiatry. I do think it's not exactly the same as seeing a patient face-to-face, but it's a reasonable facsimile. And I think that basic assessments, like, for example, emergency room kind of work, where you're doing a one-shot kind of an assessment on someone, I think that kind of work or office assessments lend themselves very, very much so to telepsychiatry, much more so than other areas of medicine. So I think the tele is particularly well suited to psychiatry. I do think that Dr. Carter, or maybe it was Dr. Wacom, said it may not be in certain inpatient situations, or in certain situations, certainly in interventional work, you can't do tele. But I think there are many areas in psychiatry that lend themselves very well to telepsychiatry. And I think the issues of e-scribing and interstate use with various licensure requirements and so forth, which are actually evolving as we speak, I think are going to open up a lot of opportunity for telepsychiatry going forward. It's certainly not going away. It's going to become more a part of clinical practice as time goes on, no doubt.
Thank you, Dr. Krugley. We're going to ask one more question and then just ask that you share your closing remarks. We're going to stay here with you, Dr. Krugley. Thinking about the residents that are listening in, very hot market, lots of opportunities. We do surveys, and our surveys indicate that last year residents are getting anywhere between 20 and 50 job offers. What would be your advice to residents right now going out into the market? They're coming up to the holidays. They're going to start making their decisions. What would you tell them?
Well, I would say I would say try to define a situation where you can be mentored. whether that's going to be and meet the people. Obviously, you're going to go on interviews, whether it's going to be a small group practice or a medium-sized group practice, a hospital-based practice or an outpatient practice. You want to meet the people, and you want to get a sense that you fit in and that you can learn. And how do you learn? You learn. It's been said by the other Dr. Wacom and Dr. Carter. The mentorship in your first few years, I'd say maybe even up to 5 years, but certainly the first 2 or 3 years, the mentorship opportunities are of utmost importance. So whatever you choose to pursue, make sure that you meet people that you're going to be working with. Make sure that you're comfortable with those people, and try to get a sense of whether you can learn from these people, because there's a lot to learn after your residency. Some of it is technical, but a lot of it is just real life stuff. So meet the people and get a sense. You have to feel comfortable in whatever setting you're going to be working in. You have to feel comfortable with your colleagues, with the people you're working with. That's what that would be my advice. Yes.
Thank you, Dr. Krugley. Dr. Wacom, question to you. What would be your advice, your words of wisdom to residents as they get ready to enter their first move?
Yeah, just echoing what Dr. Krugley said, fit is important, right? It isn't work if you enjoy what you do, sort of thing. So making sure that the team and the opportunity matches what your desires are. Obviously, there's a financial component to this. As Dr. Carter mentioned earlier, there's a component of like personality and fit and what makes sense, like work-life balance. So, one thing I can tell you is it doesn't matter how much money you make if you don't like who you're working with, or you don't find the job enjoyable, or again, the job is a direct clash with your personality type, then you won't be in it long. I think Dr. Carter also had mentioned what we do is tough. We shoulder a lot of information from patients. Our job is not easy, and so we have a high burnout rate. And we treat very complicated people in the inpatient setting, but we treat complicated people in the outpatient setting. We get some horrific stories that we hear. So, I think it's really important that you think about work-life balance. You think about personality fit. You think about the financial component, but what that means for the longevity of your career and what really excites you. Because again, if you love what you do and you're truly excited by it, and it doesn't feel like work, you will ultimately be very successful, and people will come from everywhere to see you, or come from everywhere to be part of what it is you've built. So, I can't understate how important that fit and, the balance can be.
Thank you, Dr. Wacom. And Dr. Carter, lastly, I'm sure you give advice to your residents. Could you please give those same words of wisdom or others to our greater audience?
I reiterate everything that's been said, but I'm going to take it to kind of a different point too, is to remember that as a physician in the room, you are a leader. Title, no title, what you do is being seen by students, by other disciplines, by your patients, by everyone. And kindness matters. Can't tell you the number of people and meetings I have on a daily basis of physicians who are inappropriate and unprofessional, is to recognize that it's a privilege to do what we do. And it's so, so, so important to be kind and compassionate, to include and build up. Everybody probably on this call was a student or has felt in over their head and doesn't know what's going on. Medicine is still a ladder or a totem pole. You may be in the middle, bottom, top of that totem pole, but you should be looking up and below to bring people with you or to keep scaling up. And it's a relatively easy thing to do, even when you feel like you're lost and don't know and trying to learn and figure things out yourself. kindness and just empathy and leadership are vital and will make all the difference of continuing your career in a positive way.
And it's been my personal humble privilege to converse with the three of you. Thank you so very much. I'm going to turn this back over to Leah to close us out.
Wonderful. Thank you so much, Michael. And thank you so much to our three panelists as well. We have extreme gratitude to each of you for taking the time to join us and share all of your insights and thoughts on what you wish you knew before becoming a psychiatrist. To all of the participants, we are grateful for you joining. This session has been recorded and will be publicized on the Merritt Hawkins LinkedIn page, as well as our YouTube page. If you have any questions at all, please feel free to reach out to any Merritt Hawkins representative, as we will be more than happy to assist. Aside from that, thank you so much for joining us today, and we hope you have a wonderful afternoon and/or evening.